All right, YouTube, how we doing? Waiting on Instagram here. All right, we are live on Instagram. We are live on YouTube. Welcome to the PT on Ice Daily Show, brought to you by the Institute of Clinical Excellence. Good morning, y'all. Hope you're doing well. My name is Dustin Jones, one of the lead faculty members within Modern Management of the Older Adult Division, MMOA, as many of you all know. Good morning, folks rolling in here on Instagram, YouTube as well. Thank you, podcast listeners. We appreciate you listening to us on your commute or when you're doing your dishes. Today's topic at hand, falls training across the spectrum. Falls training across the spectrum. So we're going to get into a big, somewhat controversial topic in the realm of geriatrics, but you're going to learn this is not a geriatric issue. This is just a human issue of teaching people how to fall and why we may want to do that. Before we get into the goods, I want to speak to some of the MMOA courses coming up. This is a very busy time for us in MMOA. We are kicking off the last online cohorts of the year of 2022. Essential Foundations. MMOA Essential Foundations starts next Wednesday, October 12th. Those seats are filling up. That is an 8-week online course, cohort style, very interactive, weekly assignments, weekly meetings, making sure that you're able to apply that information. For those that have passed and completed Essential Foundations, you have the opportunity to take MMOA Advanced Concepts, which starts tomorrow. There are 3 seats left currently. That is sure to sell out, so I would grab that sooner than later. And then we have our live courses as well. The October 15th, we're going to be up in Anchorage, Alaska, and then over in Delaware. And then November 5th, we're going to be in Cheyenne, Wyoming. So for those that complete all 3 of those courses, Essential Foundations, Advanced Concepts, and Live, you get your CERT MMOA. You're certified in modern management of the older adult. Awesome. All right, let's do this. Falls training across the spectrum. I had an awesome interview that we're going to publish on the MMOA podcast with Stephen Kinney. So just for a little bit of context, Stephen Kinney is a researcher. He is a professor. He's a physical therapist. But about couple years ago, started to do a revamp of our falls prevention lecture in modern management of the older adult. And as I was diving into falls prevention and just looking more at the research, you start to see that we are really ignoring a big chunk of the encompassing term of falls prevention. We focus so much on what we do before a fall happens in terms of addressing risk factors, of maximizing physical capacity, addressing extrinsic risk factors like fall hazards in the home, for example. And we do a miserable job, no job at all. We just completely ignore it, of preparing people for the event of a fall, how they fall, can they fall and minimize that impact severity, reduce the likelihood of an injury? Are we helping them be able to get up from a fall in terms of floor transfer training? We do a pretty terrible job at that across the board. And I'll throw myself in that as well. And when I started to dive into that research, Stephen Kinney's name came up pretty regularly. He had an awesome case study that some of you all may have seen in PTJ in December of 2020 of teaching an older adult how to fall. So did an interview with him yesterday, and we fielded some questions from the MMA community. And a consistent question that we got was, when do we apply this? How do we apply this? Is falls training good for all of our patients? And with our conversation, we were saying yes, but I wanted to expand on that a little bit more today. So falls training. Why in the world are we talking about teaching people how to fall, right? Especially for some of you in the context of, let's say, busy outpatient orthopedics, where the main driver to your services is pain, right? Back pain, shoulder pain, knee pain. Why am I going to teach or show this person how to fall to the ground when all they care about is me reducing their painful symptoms, right? Or if you're in acute care, I've got Bill who's max assist. I'm just trying to get him to be able to fricking move around his bed without the use of 2 individuals. Why am I worried about a fall with him and training him how to fall? The big thing that we want you to think about is this concept of falls preparedness, of preparing people for the event of a fall. The obvious reason is that you can potentially teach them a skill that's going to reduce the severity of impact that can reduce the risk of injury, right? And a lot of research is looking at that. They're actually setting people up to the point where they're kind of rigged up, they've got a tether, they trip people or let go. And so these people fall, and they're measuring the impact severity at their hip, at their head acceleration, of how we can reduce the force that the body experiences based on some of these training techniques. That's all good stuff. That's awesome. But a bigger one that we want you all to think about is what teaching people how to fall, what that can do is really improve their fall's efficacy and improve their confidence. If I know if I lose my balance and I can handle my body weight and myself and fall to the ground and not get hurt, my confidence will typically go up. I'm more likely to do things that may scare me or I may think that I may lose my balance, right? We see this with many of our patients. As soon as they have a fall or they start to notice deficits in their balance, they really start to question a lot of activities. And when they start to question, when the doubt creeps in and the fear creeps in, what happens? What happens to their activity levels? It absolutely plummets, right? Anyone that's worked home health has seen this. Someone's had a fall, and then instead of going throughout their whole home and doing their landscaping and mowing their lawn and going to the grocery store, they may end up only traversing 2 rooms of their whole house. Their activity levels have plummeted, and then we know what happens after that, right? So the fall's efficacy and confidence is absolutely huge. Absolutely huge. That's a big benefit from this, and we want you all to really consider that. So across the spectrum, what can this look like? We cover this in MMA Live, a full 2 hours where we talk about falls preparedness and training people how to fall. I also want to plug Stephen Kinney's pre-conference that he's going to be doing at CSM the day before CSM kicks off. He's doing a whole day on showing you how to teach people how to fall, and you'll learn how to fall yourself. So I encourage you to check that out. But what we want to talk about is what this looks like maybe from the hospital all the way to the gym. So let's say we're in the hospital. Let's say we got someone like Bill who's something like max assist, right? Bill may have come down with a gnarly case of pneumonia. He's absolutely wiped out. He's probably got a lot of other issues on board that have been around for a while. He's a max assist individual. What is going to benefit Bill? So if we think about falls training, all we're trying to do is reduce impact severity, right? To reduce the risk of an injury. For someone like Bill, max assist, one of the biggest things that we want to consider is Bill's ability to maybe sit at the edge of the bed, maybe try to sit unsupported. But if he's in that sitting position, is he able to handle himself if he does lose balance? And one of the biggest risk factors for Bill is a head injury. If he is sitting unsupported, he loses balance and falls backwards or falls to the side, is he able to protect his head so he does not hit his head on something like a bed railing, for example? Or, God forbid, if he ends up falling out of his bed onto the ground, is he able to protect his head? So even a very simple technique of, let's say, rolling backwards, tucking your chin, or if you're rolling to the side, tucking your chin away from where you're rolling, can protect his head, put his neck in a solid position to where when he does fall back, he's not going to have that whiplash sensation and end up having some type of concussion or TBI, for example. That's how it can apply to Bill. We can also think about what about his upper extremity strength and power and his ability to handle his body weight when he may fall forward or fall to the side. Are his arms able to help out, distribute some of that load, kind of reduce that impact severity? We may be wanting to train some of those activities, maybe plyometric push-ups in a very graded manner for someone like Bill. So we can start to see how that can apply to someone like Bill. Now, let's say Bill goes to a skilled nursing facility. Bill may be a mod assist, min assist at this point. He may be doing some supported standing potentially, but someone in something like a skilled nursing facility, that's very applicable. We may be doing the same things, right? We may be teaching him to protect his neck, tuck his chin with the backwards roll, with the sideways roll. We may be using upper extremities as well. We also may be doing some things in standing with someone like Bill in a skilled nursing facility when he's a min or mod assist. We may be going up against a wall, maybe a countertop, where we're working on some type of plyometric push-up where he's learning to handle that weight, disperse that load, so he's not fooshing or falling on an outstretched hand. We're still working a lot of things in sitting, but we can start to work on things in standing. Let's say we're in home health. All right, Bill gets discharged. He's at a solid contact guard assist, probably with the walker, probably with the cane, something along those lines. He ain't going out in the community much. He's in home health. What can Bill do in home health? We're going to do all the same things, but we may work on when he does experience a fall, how does he distribute that load? How does he reduce the load? And we can do that in reduced ranges of motion. So instead of doing a full fall from standing, we may get Bill in quadruped. We may get Bill in tall kneeling and working on that forward fall where he is distributing that load, catching his body weight, distributing that load across his arms, and not fooshing or falling on that outstretched hand. That is very applicable for someone like Bill. We can work on that backwards roll where he may be sitting on the edge of the bed, rolling backwards, working on tucking his chin, falling to the side and sitting. We may have him stand up a little bit so we increase that range of motion and he's falling back on the bed or a chair or a couch, for example. We can gradually change that range of motion to scale it up for someone like Bill. All right, let's say Bill, you're absolutely crushing it with Bill. That contact guard is no more. That cane is collecting dust in the corner. Bill's going to outpatient. He is independently ambulating, driving that nice Buick sedan to your clinic. What are you going to do with someone like Bill? We're going to continue to increase that range of motion. So instead of sitting and doing a backwards fall, we're going to be in standing. And what we can do is lower that surface gradually to where we're increasing that range of motion of his fall. Working on him getting low, protecting his neck, being able to distribute that load to reduce that impact severity. Same thing going forward. We can start to use mats where we have, the old school gymnastic mats or bouldering mats that you would see in something like a rock climbing gym. Or if you have a really good high-low table, big therapy mat table. Or if you're lucky, you've got grass. You've got a grassy area outside. Better yet, if it's a grassy area and it has a slope, because if it's at an incline, we can ultimately reduce the range of motion of that fall. We can make it very, very inviting and not as intimidating for someone like Bill in outpatient. You also have the luxury in many of these settings for a lot of guarding, right? Transfer belts, gait belts, all kinds of stuff to make this safe. Let's say Bill's done with PT. I'm out, discharged him, see ya. Let's say Bill goes to a gym. He's in a fitness facility. Man, Bill can do all the things, full standing fall, probably on some type of softer surface. If you're in a CrossFit gym, some of your CrossFit boxes will have kind of the big rollaway mats that a lot of people do gymnastic work on or handstand push-ups, things along those lines. Those are great for falling. You can get bouldering mats and other mats, and you can do full range of motion falling forward, backwards, to the side if you're feeling crazy. That's how we can progress it. So all you need to think about is how can I reduce the severity of impact upon a fall, right? To reduce the risk of injury. And throughout that spectrum, what we're mainly doing is just increasing the range of motion of that fall. When we're in the hospital, we may just be sitting, right? And working on tucking the chin. We may be doing some seated plyometric push-up type work to work on that upper extremity support. And as we progress and get more independent, we're just increasing that range of motion to the point where we're doing a full fall. Now, if that feels like, what in the world are you talking about? I cannot picture this. I cannot see this. Come to MOA Live. We do a whole 2 hours on this. Go to the pre-con that Stephen Kinney is putting on at CSM, because what's most beneficial about this is when you practice it yourself. I do not recommend you teaching your patient any of these techniques if you don't know how to do it yourself first. And we can walk you through that and make this a much less intimidating thing to think about. Falls training across the spectrum. We can do it, y'all. We can apply it to almost all of our patients. That's going to equip them with some helpful techniques to be able to use in the real world if and when they lose their balance. But the big thing is their falls efficacy and their confidence. If I know I can handle my body weight when I do fall, think of all the things that I will still want to do and not be scared to do because I know I can handle that worst case scenario. And we can do that with our patients. All right, y'all, you have a good rest of your Wednesday. Remember, EF, Essential Foundation, starts next week. Seats are filling up. Advanced Concepts, there's 3 seats left. Be sure to grab that. Y'all have a good one. I'll see you soon.